Okay, let's see now some selected synovial joints. Basically, we will talk about the major joints in our body, the knee, the shoulder, the elbow, and the hip. We will see some features regarding them, and also we will see some tendons and ligaments associated with them. Now, the first one is the shoulder, or something called glenohumeral joint. Gleno because it's articulating with the glenoid cavity of the scapula, and the humeral from the humerus. Okay, so it's articulation between the humerus and the glenoid cavity of the scapula. Now, this shoulder joint has the largest motion of any joint in the body. Why? Basically because it's lacking structural support, and therefore its stability is sacrificed to enhance the mobility. So we don't have really strong attachment between the humerus and the glenoid cavity in the shoulder joint. That's why shoulder dislocation injuries are frequent comparing to hip dislocation injuries. Remember, this is a ball and socket. The only two ball and sockets are the shoulder and the hip or the femur joint. Okay, so comparing between the two, the shoulder has wider range of movement, but it's less stable. Whereas the femur joint or the hip joint, it's more stable, but it has less range of movement. Now, the main ligaments associated with this joint are like two sets of ligaments, or one ligament and a set of three ligaments. The first ligament is something called coracohumeral ligament. Coracohumeral ligament, it's an attachment between the coracoid process. This is a marking on the scapula. This is the scapula. Okay, all of this in red is the scapula. Okay, this is the clavicle, sorry. Okay, but this is the scapula. One of the processes on the scapula is something called coracoid process. Now, from this coracoid process toward the humerus, toward the head of the humerus, this is the head of the humerus somewhere here. So there is this ligament. So this is the coracohumeral. It's coming coraco because it's between the coracoid process and the humerus. This is the name. So this is one ligament. The other group of ligaments are called glenohumeral ligaments. Now, we said that the humerus has this head, and this head is fitting within the glenoid, I'll draw it in different color, the glenoid cavity of the scapula. So here, there will be like a set of three ligaments wrapping around the head. So they are going to wrap around the head backward and front to attach it to the glenoid cavity. So these are the glenohumeral ligaments. And these are the only two ligaments you need to know for this shoulder: the coracohumeral and the glenohumeral. The knee joint. The knee joint is the largest joint, the most sophisticated joint in our body. Now we forgot something about the glenohumeral. We said this allows flexion extension. Also, it allows adduction, abduction, and also it allows rotation and circumduction. So this allows all types of movement, the shoulder joint. Back to the knee. We said this is the largest joint of the body. The knee is a hinge joint, so it only allows flexion and extension. The knee is a hinge joint that will allow only flexion and extension. However, the knee is associated with multiple ligaments that would provide support, okay? And also it's associated with different bursa and tendon sheets. Now, for these ligaments, we are going to focus only on 4 ligaments. The first 2 are extracapsular ligaments. What does this mean? If you remember, this means that they are outside the capsule. So the capsule is somewhere here inside, but these are extracapsular. And from their name, oh, sorry, the last one is wrong. And this one. So from their name, the tibial collateral ligament, it's coming from the tibia toward the femur. It's coming from the tibia toward the femur. Fibular collateral is coming from the fibula toward the femur. Collaterals, it means that they are on the lateral sides, okay, and they are 2. So we have extracapsular, the tibial, and the fibular collateral ligaments. And the other 2 are the posterior and the anterior cruciate ligaments, the BCL and the ACL, which are intracapsular ligaments. The ACL and the BCL. Now, if we look at these BCL and ACL, what do? Each one is doing like a kind of a different job. The BCL, so this is like a superior view. This is the anterior, this is the posterior. This is the BCL. And this is the ACL. Okay, now both of them are coming on from the posterior side of the femur, but they are inserted on different areas of the tibia. So both are originated, we can say origin is posterior side of femur, but they are inserted on different positions. So for the ACL, it's inserted on the anterior side of the tibia, okay? And what does it do? It resists the hyperextension. So it prevents the tibia from moving forward. So if you try to fix your leg, hold your femur, hold your thigh, and try to move your tibia frontward or forward, and you can't. So if this is the thigh, this is the tibia, okay? And if you can move it beyond the anatomical position, okay, you will not be able to do this. So if you are standing, this is the femur, this is the tibia, you can't move the tibia more than this. It's locked. Why? Because the ACL is pulling it backward. So the ACL is preventing the hyperextension. Whereas the BCL would prevent the femur from moving forward of the top of the tibia. So if this is the femur, this is the tibia. If you try to fix the tibia and try to move the femur forward, it will not happen. Why? Because of the BCL. So the BCL will prevent the movement of the femur forward. The ACL would prevent the movement of the tibia toward forward. Okay, so this is the femur, this is the tibia. This is through the BCL, this is through the ACL. Now, with that being said, there are several types of knee injuries. Usually it's associated, could be with the ligaments, could be with the meniscus, also it could be associated with the ACL and the BCL. Usually any hit on the sides of the knee could destroy these ligaments. And these are like a normal and frequent injuries in between athletes. Like in competitive sports like soccer, football, handball, basketball, and even sometimes even in tennis or other types of sports, that you will have such type of injuries. Usually the patient has to go through surgery, these will be replaced, and it might take like 6 months of recovery. Some athletes will lose their careers because of such injuries. The elbow joint, this is uniaxial hinge joint. Uniaxial, it's moving along one axis, very similar to the knee. So it only does flexion extension. So only flexion and extension. So no hyperextension on the elbow. The two ligaments that you need to know, these are capsular ligaments, so they are extracapsular. They are supporting side to side or restricting the side to side movement, and they are preventing the hyperextension. We have the ulnar collateral and the radial collateral. Ulnar collateral, because this is the ulna, so it's coming from the ulna toward the humerus, and then we have the radial collateral, it's coming from the radial toward the humerus. I think there is another one here. Yes, so this is the ulnar collateral. Okay, it's coming from the ulna toward the humerus. Okay, this one. And this is the radial collateral. It's coming from the radius toward the humerus. Part of it also would somehow like will attach to the ulna. But this is the main one. So these are the two types or the two ligaments associated with the elbow. For the hip, this is ball and socket joint, multi-axial. So it allows flexion extension. It allows adduction, abduction. Okay, and it allows circumduction and rotation. Okay, so this is freely movable joint. Well, all of them are freely movable joints, but this would provide the maximum range. Now, when we say maximum range, it's not as the shoulder. Remember, we said the shoulder has wider range of movement because it's less stable. Here, we want more stability, so we sacrifice the range of movement. In this joint, we have three ligaments that you need to be aware of: the iliofemoral, pubofemoral, and ischiofemoral ligaments. The ilium, the pubis, and the ischium, all of these are regions of the hip bone. So, for example, this is the ischium. Okay, this is the lower part of the hip bone. Okay, from this part we have the ischiofemoral. It's coming from the ischium toward the femoral. Okay, toward the femur. So this is the name. Then we have the iliofemoral. Here we have a bone that is called the ilium. Okay, so there is ligaments coming from the ilium toward the femoral. Okay, and then this bone here, this part of the bone is called the pubis. Okay, this is the pubis. So from here, there is this ligament, the pubofemoral ligament. The pubofemoral ligament. So these are the three ligaments that you need to know for. So these are the three ligaments that you need to know for the hip joint: the ischiofemoral, the iliofemoral, and the pubofemoral. Last few slides. These are about some diseases and problems with the joints. The first case is the bursitis. This is inflammation to the bursa near a joint. Usually this is because of overusing. Okay, this will cause pain, swelling, tenderness of the bursa. Sometimes it will lead to joint stiffness, usually treated with rest and anti-inflammatory drugs. Another problem is the tendonitis, also the same concept. It's treated with anti-inflammatory drugs and rest, and this is again because of the overuse. So these types of injuries, you will find them in workers on assembly lines, in workers like they are doing the same type of job or the same type of movement for most of the day, for 10 hours or more in the day. Eventually they will develop some of these symptoms. Then we have the arthritis. Arthritis is a disorder that would affect the synovial joint, and it will involve inflammation of the joints. We have more than 100 different types of arthritis. They are coming because of different reasons. Usually it's associated with aging, damaging to the articular cartilage. Sometimes it's autoimmune disease, sometimes it's bacterial or viral infections, and sometimes there is no known cause for arthritis. So one form of arthritis is something called osteoarthritis. This is the most common type. This is associated with aging, and it's a result of wear and tear. So this is because people are aged, the articular cartilage loses its ability to regenerate. And that's it. There is no treatment. Patients will be giving some drugs to calm the symptoms, to reduce the pain, but there is very limited options to treat osteoarthritis. Then we have the rheumatoid arthritis. It's widely believed now that this is autoimmune disease. Now with the rheumatoid arthritis, also there is no treatment, no cure. Patients will be giving also something to reduce the symptoms. This is not associated with age, Sometimes you'll see patients with 40 years old that they will develop a form of rheumatoid arthritis. Some severe forms of this might affect other systems because of the inflammation. They are inducing a huge amount of inflammation in the body. So again, the only available drugs that would be to deal with the pain, to deal with the inflammation, but there is no 100% cure of these rheumatoid arthritis diseases. Okay, so that's all for this chapter. Have your questions with you. When we meet, we will talk over these questions.